Today we have Dr. Aboli with us, a very experienced and seasoned professional in development sector and working in public health theme. So welcome Dr. Aboli to our channel and so
Thanks, Tukaram.
yeah. So हम शुरू करते हैं मैम सभी जानना चाहेंगे व्हाट्स अबाउट योर जर्नी आपका ब्रीफ क्या है?
Tukaram, I am MBBS doctor by training. I did my MBBS. My admission was in 1983, way back. It's long ago that I got admitted in MBBS. After that, I did post graduation in community medicine. Then I have also done diploma in reproductive health, and I also did a postgraduate diploma in public health nutrition. So these are my structured diplomas or courses which I have done. This is my educational qualifications. If you look at my professional journey, so I'll just give you a very brief of my almost 32 years of professional journey in public health. After doing post graduation in community medicine, my first association was with DANIDA, that is the Danish International Aid Agency. It was a consultancy. After that, I did almost 6 years. I worked with Family Planning Association of India. Then I worked with UNICEF, then with Japan International Cooperation Agency. With UNICEF, I worked twice, once in from 2000 to 2006, and second time between 2010 to 2012. In between, I worked with Japan International Cooperation Agency. After that, I worked with DFID supported technical assistant support team in Madhya Pradesh. It was called MP Task, and FHI 360 was the main partner of that consortium. Then, for a very short stint, almost a year, I worked with Price Water Corp PwC, where they had made a, again it was a DFID supported initiative where they had made a high level expert group, and this high level expert group came from all the sectors, like health, nutrition, education, agriculture, infrastructure, urban development, IT, skill development. So we were a group of experts, and our n- uh, TOR was to support the CM Secretariat in Madhya Pradesh, Chief Minister Secretariat, because the Madhya Pradesh government had just gone through elections, and there was a new elected government, and they had a vision document for the government. So this expert group was looking at the vision document, looking at the strategies of the government, looking at the interventions of those strategies, and providing the advisory inputs of whether the strategies are in line with what they have visioned, and whether they will be able to achieve their vision at the end of 5 years. Other task of this group was also to look at the some innovatives, or good practices within the country or in the countries of the similar settings like Madhya Pradesh, and then support and then suggest the government that these initiatives can also be started to realize the vision. That was a very interesting work. For 1 year, I did that. After that, for 7 years, I was based at CARE, where I was leading a huge nurse mentoring program across the 38 districts of the state. And we were looking at the labor room nurses, posted in labor room. And there we were building their competencies and skills to improve the RMN CHA services within the labor room, the clinical services within the labor room premises. After that, for a year, I worked with Japago, where I was looking at how to strengthen RMN CHA at the CPHC, in the CPHC program. And now, currently, since August 2025, I'm associated with John Hopkins University. They have a project where they are supporting three states, Gujarat, Odisha, and Meghalaya, on improving the CPHC program at the ground level. They have taken one district each in these states. Currently in Gujarat, my most of the time I am devoting to Gujarat, where Bhavnagar district they have taken up as a model district, and there we are supporting to improve the team competencies and team dynamics of the CPHC teams at the HWC through mentoring on the soft skills and competencies of the HWC team, and HWC team, which means the CHO, ANM, MPHW male, and ASHAs of that area. So this is my professional journey of almost 32 years.
It was good to know that it's a very vast and huge journey, and you have seen like a lot of India. So, ma'am, would like to know that what was that defining moment, like you entered into this public health. So, everybody would like to know that.
Yeah. So no, Tukaram, what is destined, it happens with you. Whatever you propose or you decide. I had never thought of entering into public health. I was always keen on doing obstetrics and gynecology, because it has a reason, because both my parents were clinicians. My mother was a gynecologist and my father was an orthopedic surgeon. So I always saw that my parents went to hospitals and they had patients and they had clinics and OTs. So I was very much impressed by them, and I always wanted to follow my mother's footsteps. But as the destiny has happened, at that time there was no pre-PG or nothing. We were given the postgraduate courses on the basis of merit. And gynecology was a hot selling cake for especially for the female candidates. So somehow I did not get the gynecology, and I was not interested in any other clinical subject. I was getting some, paraclinical like pathology or radiology, but I was not interested into that. So finally, somebody told me that why don't you join community medicine? And at that time also, when I am in this sector, I feel very sorry about this discipline, because it's such a nice and great discipline, but young professionals don't select it as a primary choice. I also did the same thing. I did not choose it as a primary choice of my post graduation course, but somebody said that if you are really want to be in touch of clinical, community medicine is one branch where you can also, you know, uh, at that time RMNCHA was the subject which was addressed in the community medicine, because of the very bad maternal and newborn indicators. So my one of my seniors said that if you join community medicine, you will be able to look at obstetrics, gynetics, pediatrics, and many other clinical subjects. It's like all in one subject. So why don't you join that? So very reluctantly I joined that, but gradually I developed interest. One, because I joined in Gwalior Medical College, Gajaraja Medical College in Gwalior, and it was one of the best departments at that time. And a very well-known figure in public health or community medicine, Dr. A.K. Govila, was our HOD, and he was an all India figure. So whenever I used to say that I am a community medicine student in Gwalior, so everybody would say, "Oh, Dr. Govila's department." So, high expectations. So that way, I developed interest into that, and then it was never looking back. I really enjoyed this working in this field.
Great to know that, and I think everybody would understand your story, how you developed interest and shift, career shift basically for a clinician. it takes a shift to get into this field. So, ma'am, like looking at your journey of 32 years, could you share like one or two, moments which left an impression on you?
Um, One or two moments, yes, definitely. I would say that, my starting was mm, uh, with, as I said, with Danida, where we were looking at, improving the skills of IUD insertion. So at that time, we didn't have the good dummies now, what we have now, no mannequins like now. I the Ladle or Gumad, we have very nice, almost real mannequins these days for competency practice. At that time, we didn't have. So we had a Danish advisor, Dr. Balthasar Shah. So he was very keen that, the skills cannot be taught sitting in a classroom. It has to be hands on. And but we cannot have real time patients to insert IUDs and let the healthcare workers practice on it. So it was a very, ethical dilemma what to do. So he came up with a dummy uterus. It was in a small wooden box with a uterus, antiverted uterus made with, a, like, you have this bulb now for suction. Earlier we used to have the suction, so we have a rubber bulb, so that bulb was used as an antiverted uterus, and the ligaments were with rubbers, so at an angle of 45 degree with proper cervix, and then not vagina but a proper cervix. Yes, vagina was developed with a cloth and all those things. And then even the labia was made of rubber and all those things. So he developed this um, a small mannequin, and we trained the medical officers on this. So although it was not a very great mannequin, but that was my impression that, the skill, and that engraved in my brain that, the clinical skills cannot be theoretical or didactic, but it has to be hands-on trainings uh, on the mannequins. So I was very lucky to have that project in the starting of my career, because that actually made it very clear that how clinical skills should be addressed. So that was one of my very good impressions that I had at the starting of the my career. My another impression, not impression, but the learning was how I developed myself as a professional was my working with Family Planning Association of India. It was an IPPF supported project, which was not only on family planning or contraceptives. It was on sexual and reproductive health. And when we say health is a, it's a holistic thing. It is not only physical but mental, social, spiritual. All the aspects have to be considered to be healthy. So that project was also designed like that. So we had clinics at the block levels, where we were providing sexual and reproductive health services, which means right from the antenatal to, you know, um, contraceptives, postnatal, menstrual hygiene, abortion services. So all reproductive and sexual health services specifically for the females. And later we also started having clinics for the males also, for the STDs and RTIs and STIs, all those things. So that was the project. But around that, we also had a non-clinical arms of the project, where we looked at the community. We looked at the community-based distributors, that how the contraceptives and other health commodities can be made available at the community level. How there can be, livelihood generation programs, so that, there were Anganwadis where children went, and their nutrition was taken care of, their hygiene was taken care of. So it was a very composite project. There I learned that health cannot work in a silo. It it is it cannot be left alone, but it has to be taken in a holistic approach, because a person who is walking into your clinic has a family behind. They are living in a community, they are living in a society, they have a family. So unless, and for especially for women, health is a very very, their own health is a very very secondary, or maybe third, fourth, no priority. It's not the first priority for them. So, if we want women to come and seek healthcare, then we'll also have to look at the what type of community and society and family they're looking in, they're living in, and then work around that, so that there is a network or a safety net around that woman and the child, so that they can seek healthcare as and when required and not delay it, because we have seen that delaying it leads to unwanted pregnancies, leads to sexual and reproductive tract infections, leads to unsafe abortions, all those things. So that was also a very very, what you say, a very strong impression which had that project had made on me. And I developed as a public health professional, look taking the holistic approach towards health.
Okay, okay, ma'am. So after this long 32 years, like you started with your Gwalior thing and that project that developed interest in you. But like we all would like to know what kept you going through all these 32 years and still you are counting. So what is that thing?
um, One basic emotion with this discipline is that, you see, you can be part of a change on a mass level. That is the best part of this. I always think that had I been a clinician, uh, how much I would have done. Of course, I would have been satisfied because that was my first love. So, but now if I compare, I see that, as a clinician, you take care of a person, but with this discipline you take care of a society, of a community on a mass level. You improve services, or you improve the quality of life on a wider perspective, and so many aspects are there. So that is one thing which I really like about it. Other thing is, I also feel that I feel a sense of satisfaction, because I feel that it's sort of a social work, what public health people are doing, where basically, because we are working through government, primarily through the government system, and where the government system touches upon the last person, on the in the society, and provide services to them. So if we are able to improve the quality of life of that, of the last mile population, that is very very satisfying. That is the second thing. And the third thing is, because I have been in working with so many organizations, and every time the geography, either the geography was different, or the interventions were different. So every time it was a new learning for me. And now also when I'm working with JHU, it's a new learning, because I had never worked with the at the subcenter level or the HWC level. So that is again a new learning. So I still feel that there are so many things that I can still learn and acquire as my skills. So that is also one thing which has kept me going. And I still look forward for, I think, at least a decade or so to keep on working.
Sure, ma'am. Sure. We all also hope that you continue with your passion. So, ma'am, like in your complete journey and in your domain, like your expertise domain, so what changes have you been witness to? Could you please share that?
Yeah, so many changes because in 1994 there was this what ICPD, no? That was for family planning, where our contraceptive prevalence rate was very, very low. We had TFR as a country, we had a TFR almost 4.55 TFR was there. The maternal mortality was so high, and everybody was giving example of Sweden, how midwifery changed the scenario, how antibiotics coming into practice changed the neonatal mortality, under five mortality. Our malnutrition rates were high. Children were dying with diarrhea. So when I started my public health journey, the immunization rates were so poor. Like UIP had just started at that in way beyond in 1990. We were just starting the universal immunization program in the country. So the indicators were really bad. Then we also saw a period where the public health facilities were like abandoned. Nobody was coming there. We didn't have drugs, we didn't have diagnostics, we didn't have furniture. We just had staff and an OPD of 3, 4 people. We had seen those areas, those time also. That was the pre-NRHM era, where the deliveries were not happening. When you open the labor room, either a dog or even a cow was sitting inside the labor room because there was no patients. So we have seen that era also. But now, if you see, the country has made so much of progress, and I also take a small credit in that because I have been in this journey with the country. So I feel so good. Now, if you look at the facilities, if you go to the health facilities, they are neat and clean. One of my boss, who was a Japanese, used to say that a hospital is good if it is smelling good, because hospitals usually smelt very bad of urine, of feces, of amniotic fluid, all sort of filth was there. But now, really, if you walk into a hospital, it's neat and clean. It's smelling good. It has medicines. It has HR. It has footfall of people. The delivery rooms are being utilized. There are indoor patients. We have good meeting places. We have ACs in the hospital. We have RO. We have emergency lights and generators. So now it's like, what we were 25 years back and where we have come. It's a sea change in the public health facilities today. So um, it's I'm very proud to witness this change over the years. Though I agree that we have lot of ground to cover yet, but still we have made some progress, quite a bit progress.
And now, so looking at this development and changes over the year, so what is your vision for development sector and the domains you work?
Um, my vision is, as I said, we have to cover a lot of ground still. So two things which I really wish should happen. One is that young professionals should start looking at the public health uh, stream again, because really we need young committed professionals, especially doctors, um, who are uh, who are available for the community to provide healthcare. And I'm not talking only about curative healthcare, but we need more of work on preventive and promotive aspect, because then only we can be a healthy community and healthy society. So that is one thing. Um, Government is trying very hard to to somehow attract the young talent to the public health sector, but it's not enough. So I think we need to have something else, like, what we have been doing, it's not enough, or either it's not the correct way. So we have to find out some other ways and innovative ways to attract the young talent at the periphery. Second thing which I'm very uh, what to say, I'm very optimistic about the work happening at the HWC level. It is starting, but I think we are now. I again remember when my father was practicing at that time. Earlier, post graduation was not that, in the same breath you pass MBBS and then you join post graduation. People used to be MBBS doctors throughout their lives, and they were general practitioners. They could handle any patient coming at their doorstep. So, but in between the years, we had lost that competency of being a general practitioner, and we went too much onto, specialization. So, now the thing is that even in one organ, it's a liver, there will be a specialist for a right lobe and a left lobe. So that's not really, it's good, but it's not very good for the general community. So I think at the community health center, this health and wellness center, bringing back the primary health care so that the community gets all the services nearer to their doorstep. I'm very, very optimistic about this initiative, and I really hope and pray that, our CHOs or the health and wellness center team, they rise up to the occasion and they provide all the primary healthcare services at that. So I think the more we spread our services and decentralize it to the nearer to the community, um, it's going to improve our indicators. Of course, in RMNCHA they have improved, but now we have to look at other diseases also, uh, like cancers or other non-communicable diseases or communicable diseases and all those things. And especially, now the mental health is also a prime no problem coming up. So I think we'll have to gear up to provide services en masse on mental health.
So during this journey, so do you think like any milestones are still to be achieved, like in which in the domains you're working? So are there any milestones?
Um, yes, of course. The milestones is um, mm, I can because I have majorly worked in RMNCHA, so I can talk on that. Still, we have we have to work on maternal mortality in many of the states. The country's maternal mortality has improved as an aggregate, but there are many states which need to be worked on. Another thing is that the malnutrition rates are still very high in under five children, so that we need to work upon. Um, the new area which is coming up is the infertility, which through the government system, it's not being addressed. So the women of the lower socioeconomic status, they really don't get, and the infertility is still there. It's not that, because of the RTIs, STIs, PID, all those things, they do face infertility problems. So, and again, the increased consumption of alcohol and tobacco and all those things. So, there are uh, factors which lead to infertility, and through the government system, it is not being addressed. So, that is one area I feel that, that is a new area which the government should start thinking about.
Yes, ma'am. Like, in continuation to your discussion, the currently, so like when we say family planning, the infertility doesn't come to our mind, or it is not,
Yes.
that much built in the narrative. So I think you are saying that
Ah,
it should be a part of narrative going forward.
going forward. You're right.
And so, ma'am, like with your experience, so what would be your message to our young graduates? Those are, young graduate, I mean to say, also the MD community medicine and the MBA health management, coming from the various backgrounds like
Yeah.
non-medico, medico engineering
Um,
background. So over to you, ma'am. Yeah.
Definitely. I think this overall medical fraternity is a sector where you need to have a human centric approach. It cannot be impersonal. Um, but more so when you are talking about public health, it's more because you have to be very mindful, because for a clinician there is a face to a patient, but for public health we don't have any face to the community. We don't know uh, who our community is. We just understand what are the characteristics of that community, and we work accordingly. But I think the most important thing is that when we are working with public health, I think we should look at the last mile person, and then think that whether these strategies are going to work there or not, and be very, very empathetic about the situation at the ground level, and then um, um, design our strategies to work upon. That is one thing. Second thing, I also, in general, for the young graduates, whether they are from community medicine or they are from other clinical subjects, I think it is very important. Unless you soil your hands on the ground, um, you cannot be skilled enough. Um, Working directly in a corporate hospital, of course, it gives you very, clean incision hand and all those things. But, unless we are working at the field level, at the uh, ground level, we don't understand, because health, as I said earlier, it cannot be addressed in silos. It has to be wrapped up with the understanding of the community, society, family. So, unless we have that understanding, I think we are not an accomplished healthcare provider. Um, so I think all the graduates, young graduates, should look at that, how they can spend some time at the far off, at those areas where, with low resources, how can build in your clinical acumen more, rather than, um, you know, um, um, believing on the laboratory test or ultrasounds or MRIs or CT scans. But in that, what is happening, that our doctors are losing the clinical acumen unless they correlate it with the lab test or diagnostics. They are unable to make a diagnosis. That is coming up as a problem. So I think to develop our clinical acumen, I think it is very, very important that we sharpen our skills at such areas where we don't have this paraphernalia, and we totally believe on our training and our internal clinical gut feeling. So that I would request the young professionals to develop that, and work so that they can be even better uh, healthcare providers for the community and the society.
Okay, ma'am. So I think definitely, with, uh, with your insightful answers to the development sector's work, your work especially in public health and with the RMNCHA domain. So there are other domains also, but your work with this domain. So I'm hoping that those who really want to know like what public health professionals do and what they do basically. This is a development sector, not for profit sector. So what they do. So please you can like visit this interview and understand like someone who has spent 32 years and still want to be in the field for another decade. That is blessing for us all. People like her. There are so many people and we need much more than that because a country of 140 crores people. So thank you very much, ma'am, for giving your precious time and sharing your insights to the general audience and the young graduates to start their journey in this field. Thank you very much, ma'am.
Thank you very much, Tukaram, for inviting me for this discussion. Thank you so much.